Hi, and welcome back to the Pharmacology of the Synapse, the week of dopamine neurotransmission and Parkinson's disease. The previous video gave you an overview of what is Parkinson's disease. In this video, we will get into the neural and molecular pathophysiology of Parkinson's disease. As a reminder, Parkinson's disease is a common, progressive neurodegenerative disorder. Parkinson's disease is the second most common neurodegenerative disorder. It was first described in 1817 by James Parkinson as a shaking palsy. This disease is characterized by movement issues, including reduction and slowing down of movements. If left untreated, this will lead to a rigid, akinetic state where the patient cannot move at all or has extreme difficulty moving. At the neurobiological level, the hallmark of this disease is dopaminergic neuron loss in the substantia nigra. It requires about 80% of the dopamine neurons in the substantia nigra to be lost before motor symptoms begin to appear. Another feature of this disease is Lewy body deposition, which are abnormal aggregations of the alpha-synuclein protein. These Lewy bodies are present in a range of neurodegenerative diseases, including Alzheimer's disease. To examine how substantia nigra dopamine neuron loss leads to movement issues, we can take a look at the neurocircuitry involved in the control of movement. Substantia nigra dopamine neurons project to the striatum, and this projection is called the nigrostriatal pathway. This is part of the basal ganglia loop, where the thalamus projects to the motor cortex to initiate movement, and the motor cortex feeds back to the striatum. The substantia nigra helps to balance the striatal activity through two pathways of the basal ganglia, the direct pathway and the indirect pathway. Normally, activation of the direct pathway leads to increased activity of the thalamus and increased motor cortex innervation. This leads to movement and initiation of movement. On the other hand, the indirect pathway leads to decreased activity of the thalamus, decreased motor cortex innervation, and reduction in movement. In Parkinson's disease, the substantia nigra signal is gone. Therefore, there's an imbalance in the direct and indirect pathways. Overall, this results in an overactivation of the indirect pathway, inhibiting thalamic activity and decreasing motor cortex activity. This results in slow and rigid movements. In addition to the movement abnormalities, there are many non-motor symptoms of Parkinson's disease. The non-motor symptoms may be related to neuronal loss as well as increased disease progression. These include sleep disorders, including sleep-wake cycle disturbances, depression and apathy, memory impairment, and this can be quite wide-ranging in patients, from none and mild memory impairment up to dementia. There can be cognitive dysfunction, including deficits in attention and language, hallucinations, orthostatic hypotension, which means they have difficulty maintaining their blood pressure when they stand up and can faint as a result, fatigue, pain, constipation, and urinary incontinence. The non-motor symptoms of Parkinson's disease are more difficult to treat compared with the motor symptoms.